Hey, everybody. Welcome back to Poem Peeps. As always, Christina and I are here, super excited to be diving into another episode, and we appreciate you guys listening. Make sure that you like and review us and you follow us on social media wherever you see our content. Christina, back with another Case Files episode. How's it going?
Hey, Ferv, going well. And I know we said this is one of our favorite types of episodes to do because we get to meet people from around the country, amazing educators, and hear about case and highlights from our peers. So, really excited today. We're actually virtually visiting Northwestern. I still think if we're going to go on our bus one day and visit all of the fellow and program leadership that we've had on the show. So, looking forward to that. But let's
Yeah.
go ahead and get started. We have three amazing guests joining us today. And first, I'd like to introduce Dr. Jamie Rowell. Jamie's a first-year clinical fellow in the Northwestern Pulmonary Critical Care Medicine program. She completed medical school at the Medical University of South Carolina, and she did her internal medicine residency and chief residency at University of Vermont Medical Center. So a couple of different institutional experiences, Jamie. But we're so excited to have you on, and welcome to Plum Peeps.
Hey, thanks so much for having us.
Yeah, absolutely. Next, we have Dr. Kathy Gao. Kathy is an instructor of medicine at Northwestern, and she completed her pulmonary and critical care fellowship there. Her research focuses on using machine learning applied to ICU electronic medical record data to characterize patient trajectories and identify potential interventions and improve outcomes. Pretty hot topic right now, so I'm sure we're going to see some cool data coming out. Thanks for coming on the show, Kathy.
Thanks so much for having us. Super excited to be here.
Yeah, great to have you. And rounding out our guest for today, last but not least, is Dr. Claire Schradel. Claire is an associate professor of medicine and pulmonary and critical care and medical education. She's a program director of the Northwestern Pulmonary Critical Care Medicine Fellowship Program and has a keen interest in medical education as well as simulation. And we're so glad that you can join us today, Claire. Welcome to Plum Peeps.
Thanks for having me. Excited to be here with you and my colleagues from Northwestern.
Yes, and we'll go through our case, and we definitely want to learn everything that you love about Northwestern, and we'll have some time for that later. But just to get it started, we'll do our quick disclaimer. So just as a reminder, this podcast is not meant to be used for medical advice, and the views we express today do not reflect the opinions or policies of our respective employers. The case we'll present today is going to be HIPAA compliant, and some details may have changed to protect the privacy of our patient. All right, Jamie, I'm excited to hear and anticipating our discussion today. So let's go ahead and dive into the case. And Jamie, do you want to go ahead and tell us about the patient that you met and how they initially presented?
Yeah, absolutely. So we will be starting off with our patient, who is a 25-year-old female, otherwise healthy, who has had multiple healthcare encounters over a few months for recurrent right-sided chest pain and cough. Her story kind of starts in October. She was seen by her PCP for these symptoms, received a course of antibiotics, and felt a little bit better, but not totally resolved, and then presented again to the PCP in December. Had antibiotic round number 2. Pain improved, cough was still present, and she developed a new symptom of breathlessness that developed over the ensuing months. In February, she was seen again, and really at this point, it was the intense right-sided chest pain that was causing her a lot of problems, really interfering with her daily life. She was given a prescription for high-dose NSAIDs, which she took 3 times a day for several weeks, really didn't have much benefit. And then we're meeting her 1 month after that. She had an episode of coughing up some bloody sputum, which prompted her to present to the ED for evaluation. At that time, she reported that her chest pain remained right-sided, worse with deep breaths, improved in between those episodes, and her shortness of breath had worsened. It was really interfering with her activities of daily living and her exercise capacity. She is a runner, used to run 5 miles, but now really struggling to make it through 2. She did not report any unusual exposures at that time. She did tell us that she went to undergrad in central rural Ohio. She does not have any other significant pulmonary history, no exposure to mold, doesn't vape, doesn't smoke, and no significant animal exposures.
Thanks, Jamie. That's great. This is a really interesting case already. A few things that are of note. First of all, 25-year-old coming in down from 5 miles to 2 miles, very concerning to me and interesting because often we would ask someone in the ED or in our pulmonary clinic, how much can you do on exertion? And if they say I can run 2 miles, you'd be like, you're great. I'm sure CPAD is normal still, but she can run 5 miles before. This is a huge decrease for a healthy 25-year-old. So my antenna are very much up. Hemoptysis, right-sided chest pain, the works with deep breath has this sort of pleuritic nature, prescribed NSAIDs. I certainly am worried a little bit about a pulmonary and pleural process. As we know, and for our listeners, your lungs are not innervated, so you can't have right-sided chest pain from a pure intrapulmonary process. But if it extends into the pleural, then you definitely can have symptoms like this. So already I'm thinking about infectious symptoms, infectious etiologies. Certainly, it doesn't have to be esoteric. This is how young people present with empyemas. They have a pneumonia, they treat it as at home, or they get a walking pneumonia regimen, and they come in weeks later and they have this dense empyema. Now, she doesn't sound quite that sick. It's a little bit of a long course, but that could definitely do it. Just the central rural Ohio, if you were taking a test, this would be histoplasmosis. So we think about things like that. And then if we were in a different place, and depending on where other social history, this is how TB pleurisy presents for sure, right? So TB would definitely be on your differential for a patient like this as well. Any young person who's having symptoms of maybe pleuritis, I'm thinking about autoimmune disease, certainly lupus could do things like this. A variety of autoimmune diseases do this as well. With the hemoptysis and right-sided pleuritic chest pain in a more acute setting, we would think about PE a lot. And certainly stuttering CTEP can do this, right? You get clots and then you have some remodeling recurrent clots. It's a little unusual. And we don't usually the breathlessness is the more prominent pain over time than just the chest pain. And then you mentioned no unusual exposures, but if she has a pneumonitis or recurrent exposures in the home that she doesn't know about, then that could do it. At the same, also organizing pneumonia can present like this. Again, usually more breathless and less pleuritic, migratory resolving presentations for non-infectious pneumonia. So a bunch of things that are already on our background, are already on our mind. I'm sure you took some more history and background for this patient. Could you give us a little bit more details?
Yeah, absolutely. So in terms of her past medical history, really only notable for major depressive disorder for which she's on citalopram, which is her only medication. She has no surgical history, no known drug allergies. In terms of her family history, only notable for a mother who was recently diagnosed with a BRCA-positive ovarian cancer, no other malignancy history in the family that the patient knows about. For social history, she's a never tobacco smoker. She does use marijuana in edible form about 1 to 2 times per month. Only occasional alcohol consumption, again, 1 to 2 times per month in social situations. And then her exposures, we mentioned the undergrad in rural central Ohio. On exam in the ED, she's well appearing, afebrile. She's hemodynamically stable and satting 100% on room air. A physical exam, really otherwise only remarkable for inspiratory crackles in the right lower lung fields. She doesn't have any rashes on the skin, no GI findings, no cardiovascular findings. Full lab workup obtained in the ED, notable for a normal CBC, normal BMP, and hepatic function panel. She had inflammatory markers that were slightly elevated, an ESR of 42 and a CRP of 17. They did obtain a D-dimer that was high at 987, and then a quantiferon gold was negative.
Awesome. Thanks so much, Jamie. And I know somewhat limited information, but you've gone through so much, I think, already that is starting to help us frame the case a little bit. Some pertinent positives that you mentioned, but also some pertinent negatives. I think one thing I wanted just to bring up more was that she doesn't have a smoking history. And Ferv and I, in one of our prior episodes, we talked about how a smoking history can make pneumothoraces more likely. So having that on the differential. So I would be considering that more if she was a smoker. I think also gender with being male is a little bit more a higher incidence of having pneumothoraces with associated smoking. So slightly taking that away from the top of my differential. Otherwise, though, you mentioned labs are pretty unremarkable. A chronic and ongoing systemic process or infection. Firth brought up empyema that can present like this. That's seeming less likely as well as this time. Mildly elevated inflammatory markers, which I think the five of us are probably like, oh, like what do we do with that? They're a little bit abnormal, but let's see what else shakes out. You did mention her mother has a history of BRCA positive ovarian cancer. So although the patient you're presenting is very young, we still need to consider malignancy as given her possible risk factor. And I think your exam was great and actually tells us quite a bit. She's saturating 99% on room air. So the fact that her dyspnea on exertion makes us now more concerned about three different type of buckets that I would frame it. One is going to be a diffusion limitation process, which can manifest as reduced DLCO on PFTs because it's really exertional dyspnea that she's reporting. An airways process that triggers with exercise. So although this may not explain the chest pain, something for us to still consider. And the third bucket is going to be more pulmonary vascular or cardiac process with abnormal function with exertion. So I think some of us are probably thinking on here that you want to see imaging, but we also before that we want to see what's her ambulatory O2 saturation. And finally, Jamie, you mentioned that she did have some crackles on exam without distant breath sounds or dullness, making a pleural process overall less likely. How am I thinking about this patient, the problem representation right now? I'd say that we have a 25-year-old woman with recurrent progressive right-sided chest pain, cough and dyspnea, who has a significant decline in exercise capacity, who is stable on exam at rest and only with some mild lab abnormalities. Kathy, I think we could see this type of patient present in multiple different venues, maybe going to urgent care, maybe going to the emergency department for evaluation, but we also maybe meeting this patient in clinic for the first time as primary evaluation or maybe coming in for secondary opinion. I'm curious, Kathy, how would you go about deciding what test to initially order for her?
Yeah, thanks. I think you mentioned a lot of tests as part of maybe that would be guiding in the differentialist. I think those would be a great place to start. I think that ambulatory stat would be really helpful, especially since her symptoms seem to definitely get worse during progression. It's a relatively straightforward test of pain, so definitely want that. In some locations in the ED or inpatient, it'd be hard to get PFTs in clinic, though, especially if you have the capability to do spirometry right there. I think that's like a really helpful non-invasive, safe test that could give you some information right up front, especially if there's some obstructive process going on in the background. You could follow that up with full PFTs in the outpatient setting, and especially give you information about DLCO and things like that. And then that could be something that would be helpful to trend, especially since your symptoms have some ups and downs over time. I think having like a baseline set of PTs would be really helpful. In terms of imaging, I think chest x-ray is always a nice, good initial imaging test, quick to obtain, cost effective, and lower radiation exposure, especially in a young woman. It could help us identify if there's any really big gross abnormalities, like a pneumothorax, a significant edema, large like lung masses or consolidations, but would really have limited sensitivity in detecting kind of more subtle pathologies. And especially if we're worried about something in the vasculature, like a PE or something like that, we really want to go, I think, straight to a CTA. You could do a stepwise approach in her, starting with a chest x ray and then proceeding with more cross sectional imaging if there's something concerning there. Since I felt clearly bad enough to come into the ED, I think that would push me to maybe go straight to a CT, specifically probably a CTA for her.
Yeah, totally agreed. We always want to be thoughtful and cost effective, but at the same time, some people are just getting a CAT scan eventually. So I totally agree. And Monty, thanks for bringing up pneumo. I forgot to mention that in my initial one, just Pearl. I don't. It seems like it'll be less applicable in this case, but if you had a young woman who presented like this with a pneumo, we got to do a LAM workup. A young man or a smoker, okay, they have a pneumo, could be primary spontaneous, but for a young woman, it's so atypical. Gotta rule out LAM. But Jamie, can you tell us what imaging this patient ended up getting next?
Yeah, absolutely. So, as we discussed, PE may be a little less likely in her given her chronicity of symptoms, but a young person coming in, elevated inflammatory markers, D dimer close to 1,000, she's going to get a CTA. And I think that's the right call. So, she gets a CTPE. There was no PE, but I'll take us through a read of some other significant findings. She was noted to have a conglomeration of multiple enlarged and calcified right hilar lymph nodes, the largest of which measured up to 1.2 centimeters, or excuse me, 1.6 centimeters. There was narrowing and possible occlusion of several pulmonary arteries as they coursed through the right hilum, secondary to these enlarged and partially calcified right hilar lymph nodes. Our radiology team felt that this was consistent with fibrosing mediastinitis. There was no significant narrowing of her pulmonary veins or her airways, and she was also noted to have a peripheral pleural-based opacity in the right middle lobe and right lower lobe that was thought to potentially represent infection versus pulmonary infarction.
Oh, this is great. We will definitely post these images online so you everyone can review them. I highly encourage you to take a look. Lines up really well with our exam and our thoughts. Maybe some vascular findings that could contribute to dyspnea, maybe the pleural findings that contribute to pain. I love it when our radiologist can help us this definitively sometimes and be like, "Oh, this looks like fibrosing mediastinitis." Frankly, I think if you see a few cases of this in your career, you're probably in a rare bucket. Can you tell us a little bit more about fibrosing mediastinitis? What is it and why are these images concerning for it? And what kind of things should we be thinking about once the possibility is raised for this patient?
Yes, fibrosing mediastinitis, overall pretty rare condition, as we've alluded to, and I think it can best be described as an exuberant fibrotic response that happens to some sort of trigger. And really importantly, this is a process that invades the nearby structures, the mediastinum, and importantly, on imaging, it crosses fat planes. So that's a really important imaging characteristic and why we can call this diagnosis on imaging alone. So, in thinking about how you also work or further work up this diagnosis, we really don't need a biopsy. The imaging findings can be pretty conclusive for us. And talking about the etiologies that can trigger this process come in a couple buckets. The biggest one being infectious causes. So, histoplasma, as we've talked about already for our patient, one of the leading causes of this, and certainly the leading cause in our region here in the Midwest. Other types of infection, tuberculosis, a rare cause of it, but has been documented, Aspergillus blasto, among others. And then thinking about some autoimmune processes, sarcoidosis is also a more common cause of fibrosing mediastinitis. And then you can think about IgG4 related disease. There are some case reports of ankylosing as a trigger. And then mediastinal radiation can be a risk factor for this as well. So thinking about patients with lymphoma and their prior treatment is important. And then, of course, the idiopathic bucket is certainly out there and has been described. It's really not clear why some people develop this robust immune response to these triggers, but it is quite rare. And as an example, there are some referral centers out there who specialize in this diagnosis. And one of those referral centers has reported that they only see about a dozen new cases per year. Given its rarity, and one of the things that makes it a little bit challenging is there is really no universally accepted diagnostic criteria for this. And then just to mention the kind of clinical presentation, because this condition's hallmark is invading or invasion and compression of the nearby structures, patients are often symptomatic when they present, and their symptoms largely depend on the compromised structure. Pulmonary vasculature being the most commonly affected structure with fibrosing mediastinitis. So these patients often coming in with fatigue, dyspnea, shortness of breath, and often that pleuritic chest pain. Most of the time, fibrosing mediastitis is unilateral, but know that it can affect both sides of the lungs, and those patients generally have a worse prognosis.
Thanks so much for that, Jamie, and definitely a lot of pearls that you just mentioned. I think one primarily of unilateral, and I didn't realize the point too about how the fibrosis can cross fat planes. So thank you for highlighting those two things for us. And I think as you said too, rare case, rare diagnosis, and it's really interesting. I think for us to go through it, and for those listening today, as we may encounter this in the future. And I think one topic that imaging raises is why does this previously healthy 25-year-old have fibrosing mediastinitis? And Jamie, you just did a wonderful job as walking us through a really broad and great differential. The other issue, though, I think all the five of us are thinking is what are the impact of the findings that we're seeing on imaging? And as first said, we'll definitely post them online so that you can see. But there's narrowing of multiple pulmonary arteries, and the patient is complaining of dyspnea and right-sided chest pain. So want to delve into this a little bit more. And Clara, I'm wondering if you could tell us a bit about how do you approach these imaging findings for this patient?
Yeah, of course. So when I think about this diagnosis, like Jamie mentioned, I'm thinking about which structures are being compromised. Is it my arteries? Is it my veins? Or is it my airways? And each of those structures is going to result in a specific complication, perhaps a pulmonary infarct, pulmonary hypertension, SVC syndrome. You can get airway stenosis leading to a post-obstructive pneumonia. So there's a lot of imaging tests that can be helpful. We already have our CTA, which has been diagnostic for us as far as making a diagnosis of fibrosing mediastinitis, as well as looking at the patency of our arteries. But sometimes we need more studies. It doesn't give us the whole story, nor does it allow us to intervene on anything. So sometimes we may need to look at the veins a little bit better with another type of a CT or an MRI. An echocardiogram is really important so we can evaluate for pulmonary hypertension. A VQ scan is going to allow us to quantify what the perfusion abnormality may be from the degree of stenotic airway. But ultimately, a lot of patients will require some sort of an endovascular intervention. And so a pulmonary angiogram is going to be the test that is likely needed next.
That's awesome. Yeah. And I think my mind is going to this just the same way yours is, Clara, and yours is, Christina, is thinking about why is there fibrosing mucositis? What do we have to do about that? But then also, I love thinking about it based on the structures that are impacted. And being a pulmonary vasculophile myself, I'd love to start and delve into that. So, Jamie, could you tell us about what you guys did next for the pulmonary artery narrowing and maybe fibrosis that was seen on the scan?
Yeah, so our first step was to go to a VQ scan, as Clara mentioned, really to further assess our suspected perfusion compromise as a driver of her presenting systems or symptoms. So I'll go through the read of this. So the BQ scan showed completely absent perfusion in the right and middle, in the right and mid lower lung zones, suggestive of non-perfusion of pulmonary vessels in this location. And this correlated really nicely with our findings on CTA. So we discussed the case with our interventional cardiology team, thinking that we'd be heading towards an angiogram next, as we've alluded to, and they agreed and felt that we should move ahead with a pulmonary angiogram to better visualize the stenoses, as well as to measure her pulmonary artery pressures to see if there's concurrent pulmonary hypertension. So on this angiogram, it did confirm our findings. There was very significant stenosis of several areas of the right pulmonary artery subsegments. Fortunately, she did not have any pulmonary hypertension.
Oh, this is awesome. VQ is like my favorite test. I think it's super underutilized. I think there are three types. There's one that just looks at general perfusion. You can also get a quantitative VQ that tells you the amount of blood that goes to each type, which is really helpful for our pre-transplant patients. And then the least utilized, but my favorite, is a shunt study, non-invasive shunt study that looks at how much shunting you have from right to left and whether it's pathologic or not. This reveals a lot. And this is a really interesting management question because the patient doesn't have PH. So if they did, you might be like, we have to intervene. But also, does that mean this is the opportunity to fix this before it becomes a problem? Really interesting considerations. Kathy, could you tell us about the kind of discussions and if there's any data that would guide and help us inform this choice?
Yeah, really great question and really interesting discussion here. Totally feel like I have to say a disclaimer here because I'm not an expert on this disease. It's super rare, but I had a really great time reading about it and discussing the case with our subspecialists. From what we discussed and read, it seemed like the medical options were really limited, but there are several really interesting options for catheter-based interventions for cases that are compromising the vasculature. It can be hard to do like a full traditional open surgical procedure, just given all the fibrosis that's there. Unfortunately, there isn't a ton of data in this area, but there are several case series from centers that see a good number of these cases that describe outcomes. And there's a case series out of Mayo, a case series out of Vanderbilt, which we'll cite in the references. They showed that patients who got pulmonary artery stenting had significantly increased patency afterwards, decreased pressure gradients, and perhaps most importantly, almost all the patients reported significant symptomatic improvement in the dyspnea after the procedure. This wasn't pertinent as much for our patient because her veins and airways are okay, but there are also reports of stenting the veins and airways themselves. So we discussed this case with our interventional cardiology team who performs the stenting procedures here. And they actually said they've treated several patients with fibrosing mediastinitis in the past who have had really significantly compromised pulmonary artery stenosis. And they saw significant drops in pressures, improved functional capacity, and improved symptoms. They said, again, it's hard. This patient doesn't have pH. She's still pretty functional. She's still able to run a good amount. So would watchful waiting be an option instead for her? Our team was really concerned because she's so young. And even though she's still pretty functional, like you mentioned earlier, this is a significant drop in her exercise capacity. And could things get worse in the future? Especially our interventional cardiology team was like, it's so narrow already. If it closes off, then what can you do? Your options are really limited. So discussing with the patient who really felt concerned at how at the symptoms affecting her quality of life, opted to go ahead and pursue stenting.
That's awesome. So interesting. We'll post links to these articles and reviews that you mentioned so people can have them to reference. I think this seems totally reasonable. Say if there was a patient who is more on the borderline or high risk, another option could be like an exercise swan, right? So you could put a swan in, get them on the bike. And just because she doesn't have pH at rest doesn't mean that her PA pressures are not going up significantly with exertion.
I feel like everyone's gonna be ordering exercise swans now.
Yeah,
We're
dude,
gonna be
that's
like,
it. That's what I want. Yeah, they put everyone on ECMO and do an exercise. No, just joking.
yeah. But yeah, thank you again, Kathy, for walking us through that and mention that she decided to pursue intervention. So, Jamie, just wondering if you could walk us through what intervention she had and how that ultimately went for her.
Yeah, so she did ultimately get a pulmonary artery stent with our interventional cardiology team. Angiogram at the time of the procedure is showing that severe narrowing in the right pulmonary artery subsegments. So they performed a balloon dilation and then placed drug-eluting stents into two of those stenosed segments. And as Kathy mentioned, showed significant improvement in the flow on the post-intervention angiograms. She was started on aspirin and Plavix, the plan being for a 6-month course of DAPT with ongoing aspirin after that. And she really felt a significant improvement in her dyspnea after the stent placement, so did quite well.
Great. And I think so far in the case where we've talked about fibrosing mediastinitis, we've talked about differential and some impacts that they can have on pulmonary vasculature. And I think we've done a great job in kind of the intervention and the outcome we can see from intervening on the um, stenosis. But I want to go back a little bit more to the fibrosing mediastinitis itself. And Clara, when you have a case like this, what type of diagnostics are you thinking about to confirm the to confirm the underlying etiology?
Sure, of course. So, as we mentioned, it's very rare and typically it can be diagnosed just on imaging. But determining the underlying cause, why it started in the first place, is really challenging. There is no single diagnostic test. Tissue biopsies are very risky, like we mentioned, because it's very dense and fibrotic, and there's a lot of vascular anomalies and collaterals that can form, making bleeding a really high risk of anything invasive. So, really, unless malignancy is on your differential diagnosis, a biopsy is not typically going to be recommended. And in this case, the imaging was quite diagnostic. So, it was single sided, there was a lot of calcifications. She had no evidence of other underlying systemic diseases. So, we didn't think that further invasive diagnostics with biopsy was going to be justified based on those risks. So then we start thinking about how did she get it in the first place? And really, in the US, like we mentioned, histo is going to raise to the top of our differential. But this is not an active histo infection. This could have been an histo infection from 5, 10, 15 years ago. Who knows? And it's not active infection to be targeted with an antifungal, but it's rather the really robust inflammatory response leading to fibrosis that leads to all of the issues. And the data really does not support giving antifungals in this context. In this specific patient, she had some hemoptysis. So we did want to do an airway inspection just to make sure there were no active bleeding sites within her airways. And we thought also this would give us a chance to assess her airway patency because, again, as we're thinking about arteries, veins, and airways, we want to make sure that they're not being compromised by this dense external compression. And in her case, she did not have any evidence of stenosis or active bleeding down in her airways. Now, previous reports have shown that the fibrosis is really an accumulation of CD20 positive B cells. And there's a very small case series that's looked at using PET scans to demonstrate active inflammation in the radiographic areas of fibrosing mediastinitis. This case series, done many years ago, then followed with treatment of rituximab and did see a favorable response in 3 patients. But there's really no larger trials to date, but it's certainly very interesting because to date, we're talking about interventions that are really to improve symptoms, to open stenotic airways, but we're not talking about anything that's going to get at the underlying driver of the fibrosis in the first place. So I think that's really exciting. If we can slow or stop that process, we won't need to get to the point of needing stents in the first place, which for a young 25-year-old and needing to take lifelong aspirin now, that's and possibly needing more invasive procedures in the future because it's a relentless process. Getting at the underlying fibrotic process would be really exciting.
Yeah, absolutely. That's awesome. And a great takeaway too about generally not needing a biopsy. I feel like I'm always like, we don't know what this is, let's biopsy, but it's important to have the list of things that you shouldn't be biopsying. And this is a good one I'm going to add to that. Jamie, it sounds like you guys had a lot of thoughtful sessions. Can you tell us what testing went next for this patient and what sort of shook out from it?
Sure. So backtracking a little on her initial presentation, we did go ahead with bronchoscopy given the reports of hemoptysis. Fortunately, she didn't have any signs of active bleeding in the airways. She did just have some kind of heme material, scant old blood down in the right lower lobe. Her BAL cell count was reassuringly macrophage predominant at 85%, less suggestive of infectious process. We did surprisingly recover a non-COVID coronavirus on PCR, thinking maybe that was a trigger for why she felt acutely worse. And then no significant growth on her bacterial, fungal, or AFB cultures that were followed over a couple weeks. So overall, we felt we had this young woman who likely had a histoinfection many years ago based on her kind of environmental exposures and developed this progressive inflammatory response that more recently started causing symptoms and pulmonary infarcts due to the kind of invasive and progressive nature of the disease process. And given the severity of her pulmonary artery stenosis and significant symptom burden, as we talked about, moved on to pulmonary artery stenting with really impressive improvement in her symptoms.
I feel like that's remarkable. I feel like the few cases that I have seen haven't had this positive of an outcome. So I'm glad that obviously there was a multidisciplinary discussion and a lot of team members involved and were being very thoughtful about her. So I love that. And I wanted, Claire, just wanted to go back quickly because I think you brought up such a great point about with fibrosing mediastinitis, there's no role for antifungal therapy for this, which I think is an important point. We had Emily Friedenmacher who joined us earlier or last year, and we went through a disseminated histo case where we're like amphotericin B is, that was the go-to in that specific patient scenario. But that was, is a different case and a different presentation than what we're seeing now. So again, just love that point. No specific role for antifungal therapy with fibrosing mediastinitis. But just thinking a little bit more about that, I want to go to you, Kathy or Jamie. Any other treatments for fibrosing mediastinitis that listeners should consider? Jamie, we'll start with you.
So I think we've really reviewed a lot of the things that don't work that are very tempting to try. Clara talked about the desire to give these patients antifungal therapy, given the histo or blasto being the most common causes. Really, the literature here, it's hard to make big conclusions because there's just a kind of paucity of data. And most of the data is in the form of case reviews, case series, case reports. But we really have not been seeing any improvement in outcomes with antifungal therapy. And the IDSA has come out and said that they do not recommend the routine use of antifungals for these cases. And that was part of our thought process here with this patient. And that's why we wanted the bronchoscopy in order to send off that kind of fungal workup as well. Kathy, I'm turning it over to you.
Yeah, I think similarly, if you look at the literature, there are reports of using corticosteroids to help calm down active ongoing inflammations. And while there are reports that showed that there was benefit, patients felt better with a pretty prolonged course of corticosteroids. There's been other reports where patients didn't have any benefit and you had all the complications, a host of different things that can happen with prolonged action from reasonably high dose steroids. And again, this is discouraged in the IDSA guidelines, although acknowledging it's a very limited body of data. And I think it's really a multidisciplinary care discussion in a case of a rare disease like this and really close monitoring going forwards. I think it's great. I'm super happy that she felt better after the stenting, but on repeat imaging in a couple months, if things started to look worse again, would you maybe go down the thought of, like Clara had mentioned, PET scan, something targeted like rituximab for those CD20B lymphs that we see there, something like that. And there are also sort of referral centers that sort of focus specifically on treatment of these rare diseases, I think could be consulted with if the patient continues to get worse. Fortunately, in some cases, the fibrosing mediastinitis doesn't continue to progress. So I really have my fingers crossed for this patient that hopefully she will just continue to feel better going forward.
Yeah, I'll keep my fingers crossed too. Everyone listening, cross your fingers. Hopefully it all helps. This is a great case. Really interesting. Some great learning points. I'm really excited you got to share it. And we'll definitely post some of the very cool images. We don't get to see pulmonary angiograms that frequently, VQ scans that frequently. So we'll make sure everyone can take a look at them. Thank you guys for joining us today. Christina mentioned that we love just virtually visiting all these programs and talking to people. We'd love to in person come out to all of them. But we'd love to hear a little bit more about what it's like to practice and learn pulmonary critical care at Northwestern and what you guys really like about it. Jamie, maybe we'll start with you.
Yeah, totally. So I think my kind of favorite part of Northwestern this really does give you a best of all worlds experience as a trainee, in my humble opinion. We see a ton of advanced lung disease. It makes for really excellent clinical training. There's a really robust research enterprise here and a ton of mentorship in that space if that's what you're interested in taking your career trajectory in. And then we also get divisional support in our program leadership. Dr. Stradel here, love for the meta junkie and total willingness to come onto podcasts and talk about cool cases. So I think I think it's a really well-rounded training experience.
That's awesome. We could always use more support for the meta junkies. Kathy?
Yeah, no, it goes without saying. I love that people here. I had a blast during fellowships. Of course, I've stayed and still here. And I feel like we get to see such interesting cases. And it's just really fun to be able to reach out and discuss it with local experts who, even in really rare diseases, have seen cases and are able to weigh in with their experience. It's just it was an amazing place to train, a great place to still be a junior person at. And I just absolutely love it here.
That's great. Clara?
So Northwestern's been my home for a really long time since I was a student. So I've really grown up here, but I stay because of the collaborative environment. The fellows and the faculty, we really work together, and it just makes coming to work and get to talk about cool cases. It's such a joy to be able to be a part of the medical education enterprise and caring for really sick patients of the Chicago area. So I've never wanted to leave, and I'm happy to do more med-ed things with my fellows in years to come.
That's amazing. I feel like you're going to get like a rush of emails coming your way now, Claire, to talk about things more. Yeah, but it's been so great to have the three of you on the show today to walk us through this case and share a little bit about what makes your fellowship program so special. We end our cases with a takeaway point, and I'll start with mine. And I think I want to go ahead and go back to Jamie, as I mentioned. What is fibrosing mediastinitis? I really just loved how you said exaggerated fibrotic response to some specific trigger, and that the fibrosis can cross the fat planes and is usually unilateral. So I think that's definitely some pearls for us to remember. Firth, what about you?
Yeah, that was going to be one of mine too. That's how you can make the diagnosis. We see a lot of calcified lymph nodes. So being able to say this calcified lymph node process seems to cross a fat plane, is like a really great imaging takeaway. But I'll also take away the fact that tissue biopsy for these patients may not add diagnostic value, but also may even be dangerous. And so there's always a rush for diagnostic certainty, and you just don't need it in this case. You can make the diagnosis without having that biopsy. Jamie?
Yeah, accepting that this is a rare condition, maybe it's not something that all of us will see in our careers, but it is a complication of some very common conditions that as pulmonologists we will see all the time. So having this diagnosis in the back of our minds when we're seeing these patients, I think is super important.
Awesome. Kathy, we'll go to you next.
Yeah, this was a really great learning case for me just to learn all about the different options of management. And although the data are not strong, they're limited by this kind of small case series, learning about all the different potential options that there are was a really educational experience for me.
Amazing. And Clara?
Yeah, when I think about these cases, I like to put it in the three big buckets: the arteries, the veins, and the airways. And if you can think about that, it's very easy to think about what the downstream complication will be if one of those structures is compromised. And that will allow you to order the next best test and think about what intervention is needed.
That's great. Thank you three so much again for being on the show. We really appreciate it. Thanks, Mandeep, as always, for being my partner in crime. Thank you all for listening. If you have a similar or cool case that you want to come on the show, just make sure that you can email us, and we'll always open to hear from people all over the place. This episode was written, produced, edited by myself and Christina Montemayor. The music's original music by Eric Rogers, and we'll be back in 2 weeks with our next episode.